Okay, here we go. All right. This is Jackie Drew, and I'm the current president of the World Congress for Physical Therapy's Hospice and Palliative Care, Oncology, and HIV/AIDS Network. And I am very pleased to introduce to you this morning Virginia Pier. Virginia Pier is a physical therapist from California, from Kaiser Permanente, and she is going to be talking about an area of specialty practice for her. That's the physical therapy clinical applications for management of bowel, bladder, and sexual dysfunction. So without further ado, Virginia, would you please continue on with the presentation?
Yes. So as Jackie said, I am Virginia Pier, and I want to say a shout out to Oakland University and their wonderful oncology certification program. It's certainly one of the big reasons why I'm here today. It has really sparked my interest in oncology, and then also given the idea of merging pelvic health and oncology. So here we are today. So on to slide number 2. And this slide is one of my absolute finds, and it's from a 1911 Max Brodel illustration. And what I love about it is that it gives us a wonderful sense of how close all the organs are in the pelvis. Now, this is a female, but it still would be the same for a male, just slightly different architecture. And we can see how closely connected the bladder, the uterus, the vagina, and the rectum are. So you can also get the understanding that if you have an aggressive cancer, it can spread easily from one organ to the next. And surgery and radiation is also going to have an effect beyond where the surgery or treatment is done. And I would like all of us to have a moment of silence so that we can thank our pelvic floor for supporting all of the organs that we've got and all of the surrounding structures. Okay, so here we go to slide number 3. And there are 4 main points: chart review and clinical decision making, asking the right questions and making judgment calls about your patient and what you think is going to be best treatment for them, the physical therapy treatment and recommendations, and also very, very important is that we really are part of a multidisciplinary oncology team. We're not just off by ourselves. Next. And hopefully, after this presentation, you'll have a much better idea of how to read an oncology patient's chart, understand how cancer is staged, and the side effects of treatment, and provide basic education with appropriate exercises for oncology patients who may have cardiac issues, lymphatic problems, bowel, bladder, or pelvic floor impairment. And also, it's really important to know when there's a need to refer one of your oncology patients to a pelvic health provider in your facility or in your area. Okay, on to 6. So we're going to start with how to look at an oncology patient's chart. And step 1 is, what type of cancer is it? This gives us a frame of reference for our treatment plan. For example, if you have a patient who has colon cancer, the immediate one of the immediate things that you can go to is, okay, they're probably going to have some bowel issues. They may have scar tissue problems in their gut after their surgery. Dietary issues often are a problem. they may have constipation, they may have diarrhea, so defecation techniques are important, and then there's always exercise. When was the initial diagnosis? And that gives us some clues on how they've been affected by their treatment. Because if their diagnosis was more than 5 years ago, they might have had more units of radiation, and chances are pretty good their radiation was less targeted, meaning they've more than likely got more damage to their tissues. More lymph nodes may have been removed, especially with breast cancer and pelvic patients. When this happens, you can be thinking, they might have a higher risk for lymphedema. Chemotherapy may have left behind residual issues such as osteoporosis, CIPN, meaning chemo-induced peripheral neuropathy, and cardiotoxicity. So if a patient has had radiation on the left side of the thorax, let's say a left-sided breast cancer, this puts a patient at higher risk for heart issues. Then you want to think about how old is this patient. Older patients may do quite well with chemo and radiation if they're in good health, but if they have comorbidities such as obesity, heart disease, diabetes, osteopenia, IBS, Crohn's disease, the list can go on, or a history of incontinence, they are much more likely to have difficulty with treatment. So then it comes to, all right, why was the patient referred to PT? And it may be for a different reason than what you see presenting before you. And what I find is that most oncologists are really open to having you go to them and say, hey, this is what I'm seeing. Is it okay if I work on this? And 9.99 times out of 10, they're very agreeable. So we are now on to slide 6. So some of these clues that what the chart review is going to give us is it'll give us a frame of reference for PT treatment. When we look at the date of treatment, it also provides information regarding the side effects. And what I just mentioned in the slide before, depending on when treatment was, if it was in the beginning of the 21st century versus now, there's going to be a difference in how much radiation or even the type of chemo that was given. The location of surgery is going to tell you a lot on what you can expect for impairments and dysfunction. And the extent of the tumor or the extent of the surgery is going to give you a big idea about how big the tumor was. Usually, if surgery has been very extensive, it means there's a larger tumor, which means there's more surgery, which means probably more nodes are moved, and therefore more risk of lymphatic compromise. When you've got these larger tumors and lymphatic nodes removed, usually that means more radiation. So for a breast cancer patient, for example, that would mean that their risk goes up for developing lymphedema. The latest research suggests that obesity, axillary node dissection, and radiotherapy to the axilla those are the 3 biggies for patients developing lymphedema. And I know if there are lymphedema therapists listening to this, you might go, yeah, but there's this and this. And I certainly wouldn't argue with that. I am simply stating what the medical research has to say. Okay, next. So here we are looking at the staging system. And this, from our perspective, is yet another way to confirm what we were thinking perhaps when we were looking at the chart and the surgical report. So what we're looking at here is the T is the extent of the original tumor. And this illustration, I think, is great because you can really get a sense. Well, first of all, we're looking at a prostate. The little pink champagne bubble is the bladder up on the top. The arrow is going up. Yep, there's the bladder. And then the little, I guess I'd call it like drink stirrer over to the left is the seminal vesicle. And then the prostate is this where you see the arrow circling around. And the red little, I guess, dot or whatever, that is the tumor. So we can see it's T1. It hasn't gone anywhere, meaning it's a little tiny thing and it's within the prostate capsule. But when you move over to T2, you can see that it's gone a little bit further out and it's pushing a little bit outside of the prostate. So that means that surgery is going to be a little bit more aggressive. They're going to be poking around to see if there's any more spread. Then when we get to T3, we're looking at a tumor that's gone beyond the prostate and is now affecting the seminal vesicle. And by the time we have gotten to 4, we've gone not only into the seminal vesicle, but we've gone into the bladder, and we're really encroaching on the urethra, and we have gone outside of the immediate area of the urogenital system, and now we're starting, well, we're not starting, we are metastatic. So we've now gone into perhaps lymph node, the vessels, blood vessels, and this patient is going to have a very, very aggressive treatment. The N is how far has the cancer spread? Is it in the lymph nodes? With T3, you probably are going to start to see, well, you will see nodes are usually affected. Sometimes they are with T2. It depends if it's a late stage 2, and 100% with T4. With the M, that's going to indicate presence of metastasis. Almost all patients that we're going to see usually, well, you'll see MX. And what that means is that no lymph nodes were identified to have any metastasis. So they're pretty sure that they are not in the stage 4. When you see any kind of number, 1, 2, 3, 4, whatever, after the M, that means it's stage 4. And what we're not seeing, though, is tumor grade. And I usually don't see that except in breast cancer patients. But what the tumor grade indicates is how aggressive is the tumor. And if it's a low grade, it's not an aggressive tumor, or it's a much less aggressive tumor. And the higher the grade goes, the faster the cells are dividing and the more aggressive the cancer is. Okay, so we're on to 8 now. And I had to put it in because this is a drawing of photographs made by a couple of surgeons in 1938. And what we're seeing on the bottom left is the rectum. And the darker space towards the, yep, there you go, that is the tumor. And that is, it looks big and nasty. It's actually non-cancerous. And what you're looking above this, the rectum in the middle is the lymph node. And it's a beautiful, beautiful picture, well, drawing. I mean, somebody really spent a lot of time drawing it, but it's a lovely picture of the lymph node. And then the drawing, the illustration at the top shows the lymph nodes, and it also shows the tumor, and it looks all big and nasty, but it really isn't. On the other side, on the right, down at the bottom, it's really hard to see the tumor. It's on the distal, or it's on the right side. Yep, there it is, right there. And it's not very big looking. And then you take a look at the lymph node, and that looks a bit different. It's been affected because there is metastasis here. And what they've done is, up at the top, they drew it out, so the tumor is at the ball at the bottom. And it's hard to see, but where the lymph nodes are on the left, up at the left, there are two darker ones, and those are showing us where the metastasis is. Now, it doesn't mean it's a stage 4. It just means that it's now out of the capsule, or it's out of the rectum. And I just thought that was a beautiful picture, so wanted to share with everyone. Okay, on to slide 10. So this is a really nice illustration of the lymph system, and we can see how close the lymphatics are. The lymphatics are on the right side. It says superficial, plexus, precollectors, deep collectors, etc. And then right to the left of that are the blood vessels. And the blood vessels and the lymph system work closely together, and the lymph is always draining any excess fluid that's getting dumped out by the blood vessels. And we'll talk more about that later. But moving down, we can see we've got a nice illustration of a breast and the lymph nodes. And the big take-home message for this is when you look at the breast, it's a little hard to see with the size of this picture, but you can see that the breast has got lots of yellow in it. Those are all lymphatic vessels. So our breast tissue is packed, jammed full of these amazingly tiny little lymph vessels that are draining the lymph fluid out of the breast to the medial nodes. Those are the parasternal nodes on the right, the other right. Jackie is being very kind and running the arrow for me because I don't have the capability on my computer because it's a Mac, not a Microsoft. Anyway, so those parasternal nodes take a lot of the drainage from the breast, as do the axillary nodes. And so the big point to this slide is it's not only lymphedema of the arm to be thinking about, but if somebody's had a lumpectomy and radiation, their chances are really good that they have breast lymphedema. And it's really rare that the physicians are going to catch it. So that's something that we as PTs can absolutely do. And, you know, you can ask the patient if their breast feels heavy or full, if it just feels kind of tight and hard. Then if you are a lymphatic therapist, you can certainly look at it. If you're a pelvic therapist, you can look at it. Even if you're like an orthopedic, if that's what you do, if you're comfortable with it, check out that breast because they can benefit a lot actually from PT. It makes a huge difference for them. Okay, so next, and here is some lymph nodes, and this I think is one of the best illustrations I've seen of how they are all linked together. I think a lot of times we make visualize the lymph nodes as just these separate little beans kind of stuck around in different places. But they're actually, many of them are clustered together in like grapes. So if let's say the doc is doing, he or she injects the radioactive dye and one of the nodes lights up, they're going to be looking around to see if there are other related nodes. And if there's a cluster, they're usually going to take the whole cluster out if one of those nodes lights up. So having a sentinel node biopsy doesn't just mean one node. It could mean up to 6. I've seen up to 7 or 8, depending on how large the cluster is. So that's also something to consider, because if you've got 8 nodes, that's going to give you a higher risk for lymphedema than, in fact, if it was only 1 or 2. Also, the more surgery that is given to this area, or the more nodes removed, usually it means more digging and more, perhaps more shoulder stiffness because of the surgery. And last but not least, typically, especially in the lower tier nodes that are removed, the cut goes across the lateral aspect of pec major, and that causes a lot of shoulder stiffness. And, oh well, it causes tightness in the chest, which makes it harder to raise your arm. Okay, next. Here we're looking at tumor size. And I like this because it gives us a really good idea, visual anyways, of the kind of surgery that you might expect. If somebody has an early stage 1B, their surgery is not going to be as extensive as either the late stage 1B, and by the time you get to 2B, you've got a lot of tumor surrounding the cervix, and it's started to go into the endometrium of the vagina, and that's going to mean more radiation. Probably a lot of these people will have concurrent chemo and radiation, and that means that they're going to have more side effects, more vaginal stenosis, and we can expect that we're going to be working with them on incontinence issues, pain with intercourse, etc. So, next. Okay, so treatment. And we're going to start with chemotherapy. Just the basics. It's grouped into families. The ones that we're going to talk about are the anthracyclines, the taxanes, and the platinums. It's not that there aren't others. I'm just going to talk about the big 3. One family can serve different cancer types, and it can get a little confusing because you keep seeing, like, you associate one chemo with one type of cancer, and then all of a sudden you see it it's treating another type, but they don't discriminate. And chemo doesn't discriminate not only about the cancer type, but it doesn't discriminate about your cells. If it's a cancer cell, it's going to kill it. If it's a normal, healthy cell, it's going to kill it too. The effects of chemo are dose-related. If you have a higher dose, it's obviously going to be more intensified. And if you have certain characteristics just as a patient, you may have more side effects. And there are certain families that have more toxicity than others. And I'm going to briefly explain just what I said. So the biggies that are more toxic are the anthracyclines, the taxanes, and the platinums. They are the heavy hitters for the nerves, and those are the ones to watch out for. If you see a patient who's had any one of those, or perhaps even a combination of them, they may be at risk to have the chemo-induced peripheral neuropathy. So understanding these effects can help you develop a treatment that's more comprehensive. And it allows you to look out for some red flags, like, is somebody having numbness and pain in their hands or their feet. So let's go to next. Okay, so the big side effects are the cardiotoxicity, the chemo-induced peripheral neuropathy, like I said. Cognitive impairment is pretty common. And then, more importantly, what are the symptoms, what are the interventions, and specific risk factors. So with cardiotoxicity, it's usually patients who are 65 years old or more, or if the patient is younger than 4. The symptoms are very often subclinical for cardiotoxicity. They won't show up unless you have special testing, so don't assume that if they've had this chemo and they're not complaining of any heart issues, you can't assume they don't have some. Usually it prevents as left ventricular dysfunction. The left ejection fraction weakens. Sometimes the patient will develop cardiomyopathy, and this is especially so with combination chemo and radiation therapy. It seems to intensify the effects of the treatment. So we can, in fact, help patients improve their cardio function, but we need to be really careful when doing so. Dr. Druin is going to be speaking more about this. I'm just going to basically say that if you see in the chart that their left ventricular function has been assessed, well, or if you don't see it, doesn't matter. You always want to check their heart rate and their blood pressure before working with them in any kind of cardio capacity. I just want to see. Okay. So cognitive impairment is not uncommon at all, and I did talk about chemo-induced peripheral neuropathy. So with that, we would do the symptoms we know, balance exercise, giving them, if they need canes or walkers if it's really bad, and certainly having the neuro-PT help you out if it's more complicated than you think you can treat. Cognitive impairment, I think the biggie for us is if we know that someone has it or they say they do, they're saying they're having trouble with their memory and just, thought processes, that's a sign to us. We need to slow down, give them 1, maybe 2 things to do for a home program, and make it as simple as possible for them. Patient risk factors. Interestingly enough, African American people with African American heritage seem to have a lot more trouble with the anthraxolines. and they have more trouble with the neuropathies, the cognitive impairment, and so just to be aware of that. Okay, on to the next. Okay, so patients who have more, who require more chemotherapy are usually the ones who are the heavier ones, and with a BMI over 25. So what that says is they're probably going to have a higher risk for cardiovascular toxicity. They have more side effects, and therefore many times their chemo dose has to be reduced, and therefore it's less effective, and perhaps we may be seeing a recurrence of cancer in these folks. For the folks that are older, if they may have pre-existing cardiovascular disease, hypertension, and those with the left ventricular ejection fraction between 50 and 55%, we want to be super careful with them in terms of how we're going to work with them cardiovascularly. And the chemos that we need to be super aware of, again, are the epirubicin, the doxorubicin, and those are in the anthraxylene family. Sometimes when Herceptin, which is used for HER2 positive breast cancer, it's followed with one of the anthraxylenes, and that's really hard on the heart. And, you know, you might be thinking, oh my God, how am I going to remember all these different chemos? What I find helpful is if you just like put anthraxylene family and write them down, then you put the taxane group and you write them down. That would be the docetaxel, the paclitaxel, and the taxotere. Then you have like your little cheat sheet, and you can go, aha, okay, I know what they're going to do. Here's what I can expect. Okay, so I think we're on to the next. All right, so there's hormonal chemo. We don't just stop at like what we might think is regular chemo, but now we have hormonal chemo, and we have the aromatase inhibitors, the anastrozole, letrozole, and exestimine, tamoxifen, and then the luteinizing hormonal, I always have to read this, they are. Anyways, these are luteinizing hormonal reducing therapies. And that's the Leuprolide and the Zoladex. Anyways, these are really powerful, and what they're all doing is messing with the estrogen production in our bodies. And just estrogen is such a global, prevalent hormone in all of our bodies. It's in our tissues, including the brain, bone, skeletal muscle, cardiac muscle, blood vessels, ovaries, vagina, bladder, urethra, testes. So, a whole bunch of stuff. And when we block the abilities of the body's ability to produce estrogen, or at least block the estrogen from getting onto the receptors in the body, we are going to lose, we may and probably will lose musculoskeletal strength, including the pelvic floor, because that is a skeletal muscle. And that includes, not to forget, the urethral sphincters and the anal sphincters. We lose cardio strength, we lose elasticity in the vagina and the bladder and the urethra. So none of those things are good. And we'll get on to the fixes in a minute. Then tamoxifen, it simply blocks the estrogen going into the breast tissue. It does not affect the estrogen elsewhere. Women who take this may have increased vaginal discharge, but their greatest risk is developing DVTs. For women who for women who are taking the aromatase inhibitors, they're at high risk for osteoporosis. They're certainly going to have a lot of vaginal atrophy, trouble with bladder issues, pain with urination, pain with intercourse, and so the leuprolide, those are getting into the hypothalamus and really just knocking out the production of aromatase, and that means that there's the estrogens not being produced either. And men take the leuprolide for if they have a prostate cancer that's not responding to treatment, or it's an aggressive cancer, and that is really rough on them because it does similar to what the aromatase inhibitor does. It causes osteoporosis, weight gain, aches and pains, and not a favorite drug, but it can really prolong somebody's life. Okay, next. Okay, so you would think that radiation was just radiation, but it's really not. There's external beam radiation that has several categories. The 3D conformal radiation, which is very common. We see that a lot. Intensity modulated radiation therapy, IMRT, we see that a lot. The other ones, the tomotherapy, stereotactic, and stereotactic body therapy, are much more specialized. Those tend to be for tumors that are very, very small, or in an area where they are working really hard not to affect any other tissues. For example, the brain, the breast, the breast cancers, pelvic cancers, much more likely to see the 3D and the IMRT. Brachytherapy is when they use these little tiny seeds of radiation, and they're used like as a boost after somebody's had, like, say, a treatment of combined chemo and radiation therapy, and then at the end they'll do the little seeds to finish off the job. Lots and lots of bowel and bladder distress after and during radiation therapy. Okay, so onward. So the side effects are numerous. There's the loss of fertility, stenosis, where the vaginal tissue becomes thin, dry, and stiff. Same thing can happen with the anal sphincter and the rectum. This can lead to a decreased contractility, elasticity of the sphincter muscles, which means higher risk for incontinence, and with the irritation from the radiation, a lot of urgency. Proctitis, which is basically what that means is that there's a lot of inflammation, pain, and lots of discomfort in the anal rectal area. Pain with vaginal intercourse. Of course, I wouldn't imagine anybody who's had or having, or I should say is having radiation therapy is feeling very sexy. And pelvic fractures, radiation does in fact influence the bone tissue negatively. And then there's lymphedema. That can certainly, the risk can be increased because lymph nodes are being damaged, and so are the lymph vessels. And the biggest thing with the radiation therapy is that its effects go on and on. It's not just for a couple of months. It's not just for a year. People can have effects for many years after. And so just something to be aware of. Okay, next. So this is just really briefly, you can see where some of these nodes are for pelvic cancers. We have, if you look at a chart, you'll often see that para-aortic nodes were removed, and those are up on the abdominal aorta and the vena cava. The pelvic nodes, this illustration doesn't give half of the how many nodes we have in the pelvic area. But anyways, there's lots of them. Okay, so on. So what are the systems that we need to rehab? Well, number one, cardiovascular. We've got the lymphatic system, the musculoskeletal system, the urogenital system, the gastrointestinal system, and the neuromuscular system. So there's a whole bunch of systems. And with cardio, we're looking at fatigue and weakness. So how do we intervene? Well, we're going to test for heart rate, blood pressure, and monitor aerobic exercise. Dr. Druin's going to talk a lot about that. So lymphedema, the symptoms we'll be talking about in a bit are heaviness, achiness, fatigue, generalized numbness, tingling, swelling, and the interventions are gradual, progressive exercise, manual lymphatic drainage, laser, compression garments, musculoskeletal symptoms, diminished strength and or flexibility. So we want to do strength training and flexibility training. Urogenital, we want to, if they've got bowel and bladder incontinence, we want to work on that. Gastrointestinal, that would be more, obviously much more bowel oriented, and so defecation training, going over diet. And neuromuscular, certainly the symptoms would be pain, numbness, and yeah. And so what are we going to do? Try to help their balance and their strength and protect them from falls. So I'm going to turn the presentation over to Dr. Druin to start on cardiovascular.
Okay, thank you. I just had to turn my microphone back on. This is actually your slide, isn't it, Virginia?
Yes, but you want to, I figured you could play.
Sure. I was just sitting here thinking about what I'm going to present, and we're on the cutting edge of a lot of the things with exercise. We know it's so helpful with so many aspects of cancer, fatigue, improving function, improving, blood flow and vascularization. And, there are a few studies that are showing that people who exercise have improved bowel and bladder control, and they also have improved sexual function compared to people who are not exercising. So, those aspects of what's happening need to be better teased out. So I have a few guidelines for you, but a lot of what I'm going to say is things that we don't totally know yet about exercise, other than it's an important part of rehabilitation, just like learned back in the early days of PT school and kinesiology, that Wolff's Law, the body adapts to the stresses placed upon it, and as long as those are healthy stressors, the body will try to make itself become more healthy. I know that's very simplistic, but I think that's a good guideline for us when we're talking to patients. What I'd like to say is that the guidelines for exercise training from the American College of Sports Medicine, they were published in 2012. And one of my colleagues, Steve Morris, who's a physical therapist, he's one of the first PTs who's working with the ACSM on the guidelines that are coming out. And as we speak, they're actually writing up the new guidelines that should come out later this year. So stay tuned for those. And the older guidelines were written more for healthcare professionals. So if they were working with a cancer patient, they were a cancer patient who had limited morbidities, and they were able to function at a pretty high level. But the ACSM guidelines had many points in there where they're telling physical therapists or healthcare professionals that if you see somebody with lymphedema, or they have, hip or knee problems, or, bladder and bowel dysfunction, send them to your medical professional. So they called us medical professionals because we were part of the team that had specialty training to deal with some of these higher level comorbidities. So I'm so happy to hear and learn that the new ACSM guidelines are going to include some aspects of exercise training for physical therapists. So that's what I want to touch on with us today. I don't want to take away from Virginia's important presentation here with rehabilitation for bowel and bladder cancers. So this is starting my slide, and I think most PTs are aware that exercise helps people who have gone through different forms of cancer. Going back to the ACSM guidelines, if you even read the ones from 2012, it's a wonderful area where they talk about some of the comorbidities that the different cancers have and how exercise has been found to help them. And of course, the ACSM guideline is really focusing on the larger cancers like breast, prostate, and lung. So they're not covering all of the other cancers, but it's still a good source for seeing the current research at that time. So anyways, to continue on, some of the ways that we benefit from exercise, and most of the research has been done on aerobics, and we're starting to see more on resistance training. But the aerobics for people who have gone through cancer treatment, they find that after about 8 to 12 weeks of training, they do improve one functional level, so it's about one MET level. So that means they can accomplish functional activities or activities of daily living that require a little bit higher energy consumption. This is not always as good as apparently healthy people when they train. They can improve, about 11% of whatever their base was. But still, it's an improvement, but we can't expect the same training from someone who's gone through all the things, the chemotherapies and the radiations that Virginia has just talked about. The other thing we find is it not only promotes self-esteem, but it improves self-confidence and reduces anxiety and depression. So it helps people to have a little bit better mental health control. It is associated, like I mentioned, with improved bowel, bladder, and sexual function, but again, by itself, it's not going to make the dramatic changes that people would have if they didn't go through some of the specialty pelvic floor training. Resistance training is also important because it improves function, it increases lean muscle mass, and this is important for people who have higher weight, so obesity, because if it can increase their lean muscle mass, it's going to help them to lose weight. And we're not seeing consistent losses of weight with aerobic exercise by itself. So I strongly promote combining the exercise with not just aerobics, but adding at least 2 days of resistance training. The other thing it'll do is for some of the medications, or if somebody comes into cancer with a osteoporosis or an osteopenia, The resistance training does build muscle mass as long as that's combined with the appropriate nutritional components, you know, the vitamin Ds and the calciums, and sometimes specialty prescription medications like a Fosamax if they have osteoporosis. The other thing that resistance training does is it's good for the heart. It reduces triglycerides, which helps reduce cardiovascular disease. So those are brief benefits that I just wanted to provide an overview for. I already mentioned that ACSM is coming up with new guidelines, and they're imminent towards the end of the year. And I think it's important for PTs to understand the management methods, and particularly what we're looking for, and we don't have yet, is dosing. So we give a broad term of 150 minutes per week of aerobic exercise and 2 sessions of resistance exercise, but there needs to be more research to tell us specific doses for people during treatment and after treatment, and based on the different cancers and the treatments that they've had. So all I can say about that is to stay tuned for more information and keep up with the research that comes out on this topic. So some of the precautions that I found in the research I've been doing with my students is that if you're designing an exercise program for someone and you're trying to predict what their training heart rate range should be, the current heart rate prediction equations are not always accurate for cancer patients. They sometimes overestimate them, and I'll show you that in a couple of future slides. You may not see improvements in resting heart rate or blood pressure following training. I had some students look at that and review literature on it, and they were not able to find improvements, and I'll show that in a little bit more detail. And then most people default to, okay, well, let's use ratings of perceived exertion. Well, we have another study that indicates that women following or during breast cancer treatments are underestimating how hard they're actually working based on their VO2 levels that were measured. So let me show you some of those slides. The first one I want to show you is this slide represents heart rate equation comparisons. So for most of us who are developing a heart rate training target heart range, we would take the equation, the old equation, 220 minus their age in years, and then multiply that by whatever percentage we wanted them to exercise at, so maybe 60 to 75%. And then we could tell our patients a training heart rate range. A better equation came out a few years later, and that was the Gaelish Equation. This is described in the ACSM guidelines for exercise training. And I actually worked with Ron Gaelish on some of these projects. But his equation was 0.7 times age in years and minus 2, I'm sorry, instead of 220, you take the constant of 207 minus 0.7 times the age in years. So his equation is the green line, and the old equation, the 220 minus your age, is the red line. And for years, for decades, people said that the 220 minus the age was underestimating the intensity for older people, like you see here. It's less than the Gaelish Equation, and then overestimating the intensity for younger people. So the Gaelish Equation corrected for that, and it's now much more accurate for apparently healthy people. Well, I went to Ron with my data. I had data from women who performed maximal VO2 heart rate treadmill tests, and we did not include any ladies who were taking any medications that would affect the heart rate or the heartbeat. And so we ended up with 13 women. We had 2 tests from each of the women, and we were able to develop a significant equation for these women. And it turns out that their heart rates are about 10 beats per minute to about 14 beats per minute lower than the prior 2 equations for healthy people. So we developed our own equation, which is 207 minus 0.86 times the age in years, as being more accurate. And again, this needs to be retested in a larger population. Other researchers have suggested this. Lee Jones from UNC has also suggested that max heart rate levels may be lower among cancer patients. And what this would clearly mean is that if you use the apparently healthy prediction equations, you're going to overestimate what their training heart rate range is. And at the very least, they're going to lose confidence in being able to perform the exercises because you're giving them a training heart rate range that's higher than it should be, so the exercise is harder. But at the worst, you could actually cause some type of cardiac event in these people if you have them training too hard. So this was what we were seeing as a precaution with the heart rate equations. We repeated this. I had a student, Roxanne Filippi at Carbach, that repeated this, and she had 82 maximal exercise tests that was from 12 males and 14 females undergoing prostate or breast cancer. And the Gaelish equation on this slide is in black, so again you see that her prediction equation is about 10 to 14 beats per minute lower. And we were surprised at this because we thought only the women would have the lower heart rate, but the men had exactly the identical heart rate. And if I used to tease her that I can't believe your line is perfectly overshadowing my line in blue, and say, you know, tell her, oh, you must have made this data up. But I saw the data. I saw Ron evaluate it. And for whatever reason, even though men do not get chest physical therapy, for chest radiation that affects the tissues of the heart, it makes it more fibrotic. And many of them don't get chemotherapy, it's more radiation and surgery, even though some do get chemotherapy. They still had a lower maximal heart rate overall. So there's some effect that the cancer is having with muscles and the parasympathetic and the sympathetic system that's causing this heart rate to be lower. Moving on, I had some students look at resting heart rate changes after breast cancer treatment. So the blue was our aerobic exercise group, and the red was our control group. We had subjects, I can't remember the exact numbers. There were about 10 to 12 in each group. And instead of the resting heart rate going down about 1 beat per week from the baseline, both the exercise group and the control group saw an increase of about 8 beats per minute following radiation and chemotherapy. So this is just a precaution to you that if you're trying to motivate your patients after cancer treatment by saying your resting heart rate's going to go down or your blood pressure is going to go down, we did not find that with these patients. So they may have different training effects, even though the women who were in the training group experienced about a 6 to a 7% increase in their VO2 max, which was about 1 MET. They didn't have the other training effects with a lower resting heart rate. And again, that might be back to parasympathetic and sympathetic system. This was our study on the rating of perceived exertion. And what we did, again, these were women that did a max VO2 test, and every minute of their exercise test, we were taking their ratings of perceived exertion. And we were finding that the blue line is what their rating of perceived exertion should have been. So like during light exercise, they should have been saying, oh, I'm about at a 10. And our women were saying that they were about just below an 8, so they were at a 7.5. Again, for moderate exercise, they were reporting 12.5, and the prediction was 12.5, and they were reporting a 10. So again, a little more than 2 numbers lower. Vigorous was 15.5 for predicted and 13.6 for reported. And then the max heart rate, which should have been 19 or above, they were saying they were only at 16.8. And when we got this data, I thought initially, Well, they've just been through cancer treatment. Of course, they're not going to be reporting that they're in a lot of pain from just exercise, but we're finding now with other studies looking at heart rate variability in the sympathetic and the parasympathetic system that they may not be sensing how hard they're working, and they're, as you saw in some of the prior slides, their heart rate isn't able to generate the same maximal levels that other people, and then they're not getting a training effect. I do have one more quick slide here. This is the same data, and we did confidence intervals, and you can see that even with 95% confidence intervals, which is the green line, it still doesn't intersect the blue line. So the people really are reporting about 2 numbers lower, and 2 numbers lower, if I go back to this first slide, would be within a different category. So if the people are exercising moderately and they should be at a 12.5 for their rating of perceived exertion, they're reporting a 10, which puts them in the light level. And 13.6 is closer to 12.5 than 15.5, and then again 16.8 is closer to 15.5 than 19. So be careful using the ratings of perceived exertion because the people may be underestimating it, and it may not be the most accurate measure for how hard they're working. And so consider having them, like if you want them to do moderate exercise, have them do light exercise to begin with. And what the take-home message is from this is that, well, all cancer patients need to be screened because they're at such high risk for cardiovascular disease. If they're apparently healthy and already exercising, you can just do a survey like a PAR-Q, but it's important to screen them and then take at least their resting vitals. If they have any comorbidities or fatigue or palpitations or anything, they need some type of an exercise assessment. And PTs can do graded exercise tests, or if they have a serious comorbidity like angina or a lot of atrial fibrillation, then a physician should probably supervise this test. And the big thing that we do these tests for is to screen if it's safe for them to do the exercise, plus we can develop an exercise prescription with them. You cannot develop an exercise prescription with a 6-minute walk test. You can screen for exercise and activity levels and figure out the distance, but it's just not well standardized sufficiently enough test to do a good exercise prescription. Now, based on ratings of perceived exertion and the issues with the maximal heart rate, even these graded exercise tests have limitations for patients. So what I do is I educate my patients. I tell them that the graded exercise test is a guideline. I want to talk to you, or you might want them to come into your clinic and supervise them, which would be the best the first few times that they exercise. And then let patients know that based on how they're feeling when they exercise, you may be adjusting the level of the intensity up or down for them. And then it's really important to explain to them what to feel or what not to feel during exercise. And that's why a graded exercise test is great, because when they say they're fairly light, you ask them to think about how they're feeling, because that's all they have to do to get the benefits of exercise. Too many of these people think they have to really stress and overtrain to get the benefits of exercise, and we have to let them know that's not the case. Critical to monitor vitals during initial exercise sessions, and then, as I mentioned, adjust the intensity or the duration up or down, and then provide them with information about when to contact a physical therapist or a physician if they're having extreme fatigue, unusual vomiting or diarrhea where they're dehydrated, or any type of abnormal heart rates or palpitations. They need to contact the PT or the physician for a further evaluation. So that's my 2 cents worth, Virginia. I'll let you continue on here.
Well, I think that was more like $5 worth, but
thank you.
Extremely helpful. Just before we go on to the rehab part, this is really the rehab part here. I just want to say, you might be wondering, or if you're wondering, well, why are we talking about the lymphatic system, cardio, urogenital, when, you know, why aren't we just talking about urogenital and nothing else? And my feeling is that we're treating the whole patient, not just a part of them. And when they've had cancer, all these systems are affected. And we're going to focus, I think, we should be focusing on each system as they need. We may not be treating it ourselves, but in order for them to have the best outcome, it would be wonderful if all of us could contribute to our patients' healing. And so for those of you that have specialties in other areas, I think you're in the club with the pelvic health therapist just as much as we're in the club with the neurotherapist, for example. Okay, so here we are with the lymphatic system. So even if you're not a lymphatic therapist, just knowing the basics is really helpful. Understanding, you know, what it means to have the nodes removed, which we went over earlier, and radiation, which we talked about. But knowing the signs and symptoms of a distressed lymphatic system. And these symptoms are actually mentioned in the literature. And I think they do a good job telling us when the system is distressed. And these are heaviness in the affected region. It may not be specific, but it's in the region. Achiness, again, in the affected region. A generalized numbness and tingling. And then the more obvious is the swelling. But swelling doesn't always have to occur like in the whole arm or the whole leg. It could be actually in the ankle, or it could be in the foot. In the upper extremity, you might see it in the hand, or you might see it in the forearm. So it's often not quite as clear cut as you want it to be. What we can do, if you're lucky enough to see them before surgery, is do lower extremity measurements or upper extremity measurements. If you haven't been able to, then you see them, and if you're really concerned about the risk for lymphedema, you can measure them after. And now we're going to go on to the next slide. So, moving to pelvic floor, like what actually, was that the, I don't think so. I think we jumped a few. So go to 31. Yeah, okay. So one of the things I wanted to mention was how prevalent the lymphatic system is. It's huge. It's such a big part of our immune system. And we've got tonsils, which if you have them still, the thymus gland, which really acts more when we're very young, the lymph nodes, obviously, the lymphatic vessels. The liver and the spleen are more secondary, but they're certainly important. Peyer's patches in the small intestine, and then the appendix and the bone marrow. So with the Peyer's patches, you might get some issues for somebody who's had a colorectal cancer, or anybody who's taken chemo. It's probably going to affect the lymphatic system in the gut. Okay, next. So here, these are lymphatic exercises that they're very simple, and they're the upper extremity exercises and the lower extremity exercises. And what is key here is how we do them. And I always explain to the patients that there are two parts to any exercise, strengthening exercise. There is the contraction phase and the relaxation phase. And I actually shouldn't say strengthening. I would say any exercise. And we tend to like to focus on the contraction phase, and I ask them to really think about that they are balancing that with the rest phase. Because when we're trying to stimulate the lymphatics, what we're actually doing is working the muscles around the lymphatic vessels that are traveling through the muscles. So all these exercises are done in a sequential way where we're working from proximal to distal, and we're clearing out, or stimulating in this case, the lymphatic system to help it work a little bit more efficiently. So these exercises are done with like a 2-count contraction and then a 2-count rest phase. And that allows the muscle to contract, push the fluid out of the vessel and push it, it's going up, not out of the vessel, so moving the fluid up. Then that 2-count rest phase allows the fluid to, the vessel to reset itself, and then the next push. So you get a really good, effective pressure moving the fluid upward, or wherever it's going. Now, the diaphragmatic breathing, if your patient's unable to do anything, is really a biggie. For two reasons. When we inhale, the diaphragm, which connects the pelvic floor muscles, well, I should say it connects to the pelvic floor muscles via the transversus abdominis, which has an intersection with the pelvic floor muscles, drops down and out. So on the inhale, the diaphragm's dropping down and out, and as that happens, the pelvic floor is going into a little bit of a stretch. On the exhale, the diaphragm moves in and up, and the pelvic floor is going to contract a bit. So if you are teaching someone this breathing and you're concerned about their pelvic floor because they've got incontinence or they're talking about they have pain, then you want to make sure that they're not pulling hard into their belly on the exhale. So you want to keep it maybe at a 50% max to prevent overstimulating the pelvic floor. Okay, next. So on to 33. Did I lose you? There we are. Okay. So in the musculoskeletal system, what we're going to be looking at are the pelvic floor muscles, which if you are a pelvic floor therapist, then having an assessment internally is really great for the abdominals and the lower back, checking them out with just manual muscle testing. Lower and upper strength, again, manual muscle testing. If you're going to be working with your patient and you want to get them doing some weights, you always start at the lowest weight possible. And I'll talk a little bit more about that later. You just start with 10 reps. And the other part to starting a cancer patient who's had radiation and chemo and maybe nodes removed is talking to them not only about their fatigue that Dr. Druin was talking about, but also the signs of the heaviness, achiness, fatigue, numbness, tingling, and swelling. We call them half-nits. those are always to be in the back of their mind, and like I said, we're going to talk a little bit more about that later. So let's go to the next slide. So here we have the pelvic floor, and I simply put this in because I love it, and it's a great way to just get a sense of all the muscles and how closely connected they are. And one of the very interesting things about the pelvic floor is that when you contract a muscle, meaning it's probably going to be, you're going to be focusing on either the front, the urethra, or the anal, the backside, all of the muscles contract. So it's an all or nothing affair. And so moving on. Okay, so how do we do a pelvic floor rehab exercise? Now, in the best of all possible worlds, you would be able to do an internal. You can do that usually 6 weeks after radiation and or when the patient's been cleared by the MD. The internal exam gives you really valuable information. What you're looking for is this tissue thin? Is it fragile? Are they able to contract well? Can they release well? Often, patients who've been through their surgery and radiation and chemo have very held pelvic floors. They go into kind of like shock mode. So while they can contract, they don't really contract strongly because they're already holding, and they have a very difficult time releasing back to a normal resting tone. So even if you haven't done a pelvic floor exam because you're not able to, then what I would do is I would stay away. I recommend in the beginning staying away from the strengthening side of the Kegel and focusing on the stretch side. You want to give the pelvic floor a chance to lengthen and get its mojo back. And a modified child's pose, what that means is it's a child's pose, but the difference is you have your feet together and your knees apart. It's actually a very important distinction because when the knees are apart, you are actually separating well, you're not separating the IT bones, but you're opening them up. And then since the pelvic floor attaches to the inner sides of each IT bone, that gives a really nice pelvic floor stretch. Happy baby is when you bring your knees up towards your shoulders, so it's a nice wide spread, so to speak. And you get a good pelvic floor stretch, and it can also lengthen the hamstrings and a little bit of the adductors. The figure 4 stretch can be done in sitting or supine, depending on the size and flexibility of your patient. And that's more for the obturator internus, which is actually not part of the pelvic floor, but the pelvic floor attaches to it. And then the supine frog with your thighs on pillows. And I hope all of you have a visual of that. Okay, next. Okay, so just basic core and lower extremity strength. Trying to do a balance of lymphatics and strengthening, because especially if somebody's had a pelvic cancer, we want to be thinking about those lymphatics and also strengthening. So that means that The contraction phase is done a little bit slower on a 2 count, and then there's a little bit more of a rest phase than we're used to. That's also the 2 count. So that's the activating the muscle pump is the breathing, but also when you do your glute squeezes, you are involving lymph vessels as well. Clams for the hip rotators, bridging, bird dog, which a lot of times needs to be modified for a lot of patients, so I might have them do just 1 arm in extension or 1 leg in extension before they're able to do both. Sit to stand would be a nice way to do a modified squat. And then calf raises, I'll usually start both at once, and for many patients, they'll need to have, they're holding on to something. If you're going to do weights, I mentioned about like lowest weight possible. So the lowest weight for free weights is less than 3 pounds. On the machines, you want to use the lowest weight possible, and they may be balking, oh, but I used to do blah, blah, blah. Well, guess what? This is rehab, and you got to start in the beginning. And every 2 to 4 sessions, if the patient is doing well, then you can increase the weight by the smallest increment possible. But before you start adding the weight, they need to be able to complete 10 reps of each of the exercises being done. So it's a pretty, it's not fast enough for a lot of folks, but it really works because this way they're less likely to over-fatigue and over-stress themselves. But you have to motivate them to go at a lower level to get to the higher level. And most of them are pretty good about it, but they really do need a lot of supervision. All right, next. Okay, so lower extremity stretching really briefly. The hip rotators, like talked about, figure 4 is one. Hip adductors, and these are really big important stretches, especially for those that have had a pelvic cancer, because the hip adductors attach to the lower pubic symphysis, and inferior, I should say, and their attachment is right on the other side of the pelvic floor attachment. So they attach to the same bone but on different sides. Anyways, they share fascia. When your hip adductors are tight, you will be stressing your pelvic floor. So letting them know that crossing their legs, for women, that's a biggie. As I'm sitting here now, I have my legs crossed. I'm now uncrossing them. The hip adductors do influence the pelvic floor, so just remind them of that. Hamstrings, you could do any position that's easiest for them, whether it's sitting, lying down, quad stretches, and then the gastroc stretches. Okay. So urogenital system. Here we've got vaginal atrophy and stenosis, bladder urgency, incontinence, and pain with vaginal intercourse. And now we're going to talk about what to do. So next. So this is a picture of, on the left side, we've got a healthy vagina that the tissues are plump and full, and on the right side, we have a vagina that is not so happy and is thin. The ovary has shrunk dramatically, and the lining of the vaginal tissue has it's thin, and there's probably extremely little lubrication. So with the bladder, what happens after or during all this treatment? The bladder muscle can spasm because it's irritated. The sphincter muscle is probably getting weaker. As I mentioned earlier, the chemo hasn't helped a darn thing. And they say this, on this illustration, it says the pelvic floor muscle weakens, but obviously so does the sphincter because it's all going to work together. And the urethra can become extremely irritated because it's an estrogen-loving organ or structure, just as the bladder is, just as the vagina is. So they're all irritated. So what does this lead to? UTIs, burning, painful intercourse. Okay, so now what do we do? So using a vaginal lubricant and or moisturizer. I highly, 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 highly recommend that your patient use a water-based, not a water-based lubricant, period, a lubricant that has water in it with a high-grade silicone. If you just tell them to use a water base, what happens is it's nice for about 2 seconds, and then the water evaporates and it's a big sticky mess. So the silicone actually holds the water in to the vaginal tissue. These hybrid silicone, they're called hybrids, and they can be used both for a lubricant and a moisturizer. If you want, you can use a moisturizer. There are a number on the market. I do not recommend the, it'll come to me in a minute. While I'm having a senior moment, I'll move on till I remember it. Replens. Yes, Replens has a pH that is not suitable for a vagina that is irritated and fragile. So tell them to avoid that. There's something called Hyalofem and Hyalogen, which are pretty darn good. As far as hygiene, you know, unfortunately, we as women, for the most part, seem to think that if we don't use soap on the vulvovaginal area, that we're not clean. The vagina is a beautiful self-cleaning organ. It does not require soap. All it needs is just some nice, clean, lukewarm water, you know, as a daily basis. It's too bad we don't have bidets like they do in Europe, but we don't. But if you suggest that your patient get a spritz bottle and just fill with nice, clean, lukewarm water, it's a lot less irritating. After urinating, after urinating, pat dry, don't wipe. I think we spend way too much time wiping, and patting does much better for those fragile tissues. So the dilators, especially using ones with a vibrating option for both men and women, and manual therapy. So let me just say a thing about the dilators. The dilators are really important and a must-have for any of your patients that have had radiation therapy. They need someone to really explain to them how to use the dilator. You don't just insert it. Their positioning really matters. You need to be, it's much easier for most folks if they're sitting in the bathtub with nice warm water, having your back up and then the ability to bend your knees so it shortens that lever that your arm has to reach to get into either the rectum or the vaginal opening. You want them to understand they need to use a tunnel lubricant either in the anus or in the vagina and then all over the dilator. When you insert, it's very slow, it's very gradual. You do not push. You may feel like, you know, it's not going anywhere. Well, don't push it, you wait, and you use diaphragmatic breathing. You allow your thighs to just rest. If you're not in the bathtub, you can have them rest on pillows. So those are the kinds of directions that you want to give them. If somebody has no pain in their pelvic floor, it's just tight, then they can start using the low vibration dilator. It's very, very helpful to stimulate not only the muscles to relax, but it also stimulates blood flow. If, though, your patient is describing they have anal pain, rectal pain, or they have vaginal pain, then you do not use the vibration. It tends to stimulate more pain. So you're just going to use like gentle stretching with the dilator. There's also something called a crystal wand. Jackie, can you go to 42? Okay, so this is a crystal wand, and you'll see one of them has like bulbs on the top, and one of them is just like plain. This is really good for the vagina. I don't really recommend it so much for the rectum, although I suppose it can work with the right patient who has pain. But anyways, back to the vagina. You insert it into the vagina, and what you're doing is you're finding the trigger point, and you can apply the end of the wand to the trigger point, and you apply a firm but gentle pressure, and that can be a way to help reduce and work out that pain, and then you have them just massage throughout the pelvic floor that you can reach through the vagina. Okay, so 43, and here we have a picture of the vibrating, well, it's one of the vibrating dilators. And there are several different types. There's the Famani, there's Laura Berman, there's Velvy. Cost is an issue for some. So like this one that you're looking at is the Famani, and it's one of my favorites, but it's expensive. Well, Laura Berman is okay. It's perfectly decent. It's less expensive. The Velvy is somewhere in between, and then there's something called Soul Source dilators, and they're fine too. One thing, if you're going to use the hybrid lubricant that has a water base and the silicone, most of the dilators will tell you do not use a silicone-based lubricant. Apparently, it over time breaks down the material of the dilator. So what I recommend you tell your patients is get the non-latex gloves at the drugstore, and you just put one of the fingers of the glove over the wand, the tip of the wand, and put the lube over that, and that works super well. And then you've got the best of both worlds. Okay, next. Okay, so we're down to 44, I think. Okay, so erections. Okay, let's talk about men for a second, because I think they kind of get a raw deal here. And so we want to educate the males about the erectile dysfunction that often happens after prostate cancer. So it's not just about, well, there's two big things going on. It's about blood flow, and it's about the nerves. And one of the things that happens with the surgery, sometimes the nerve plexus that serves not only the bladder, but the erectile function gets either cut or stretched, or a combination of both. And when this happens, the nerves become stunned. So even though most of the nerves are still intact, or perhaps even all intact, the penis does not become erect, and it won't until those nerves recover. There are men who recover really quickly, but within 3 months, but for some it can take quite a while, and the numbers that are out in the research are 2 years and 3 years. I said 3, and I will usually tell my patients that, especially if they're a difficult case, because I want them, well, I always hope that it will make them feel better because they still have trouble. All right, so what do we do? So we are going to reinforce the use of Viagra. That really does help because that stimulates blood flow. The penile pump, because that puts the penile tissues, especially the tunica albuginea, which, Jackie, can you go down to the next slide? Okay, so the tunica albuginea is that looks like a little bee, honey bee cone, like it's the purple, like open spaces on the penis itself. Yep, there you go. That's the Corpora Cavernosus, and that's where the blood comes in, and when those little caverns get all full with blood, they press against the I'm going to call it the capsule that's around the cavernosa, and that's called the tunica albuginea. And so what we want to do is we want to get these caverns filled with blood, and then we want them to stay there. So using a cock ring at the base of the penis, so that's near where the prostate is or was in some cases, and you put the cock ring on, and if you combine it with the pump, you get a lot of stimulus, so that the stretching helps to stimulate blood flow, and the cock ring helps to hold it in. The other thing that can be helpful is using a dilator in the rectum. That can help it. It looks like the rectum's like really far away from the prostate. It's actually not that far. And with vibration to the pelvic floor, that's going to help stimulate blood flow to the corpora cavernosus. So there's a lot of ways that men can self-stimulate as well. But anyways, they'll need to choose what's the most comfortable for them, and certainly they can have their partner stimulate them. But the biggie is that the sooner they start the self-stimulation, and they're told this by their urologist, the better, because the faster you can get the blood flow in, the more chance you've got of successful erectile rehabilitation. But granted, sometimes it's just not going to happen because the nerves were too damaged. But just some ideas for those of you that would like to try some of this stuff with your patients. All right, next. Okay, so the urogenital system and gastrointestinal. We're going to talk just briefly about some diet, abdominal massage, and the squatty potty. And so let's move down to 47. Okay, so constipation. I mean, we all laugh about it, but it's not very funny, especially if somebody has had either colorectal, rectal, anal, any of the pelvic cancers. On the left, you can see like the normal stool, and it's not, it's just fitting into the rectum. But on the right side, you see that it's really big and it's putting a lot of pressure. So that pressure is going into the bladder, which, or if you're a female, it's going to go into your vagina and then into your bladder. So it's extremely irritating to tissues that were already having trouble because of surgery or treatment. So what do we do about that? Well, let's go to the next slide. Okay, abdominal massage. And that is a wonderful trick. It's not a trick, it's a wonderful treatment. So where you start is at the ascending colon, which is at the right lower abdominal quadrant, and you stroke up to the base of the breast. Nope, that's your, I'm sorry. I'm looking at it mirror image. So the ascending colon is on, it would be stage right, correct. And you're going up, and then you get to the base of the breast, and you make a right turn, and you start moving over all the way across to the lateral side of the breast on your, that would be your left breast, and then you are going to come on down to the iliac crest, at which point you make a turn and you're going to land right underneath your umbilicus, and then you stroke down to the pubic symphysis. And this is a wonderful, wonderful way to help self-stimulate a rather slow gut. It's also calming for irritated guts that are, you know, they're still suffering from the chemo or the radiation. And even folks who have like diarrhea, I tell them to do this very, very gently. The other thing that you can tell them that doesn't have to do with the massage, but if you have them doing this after they've eaten, it helps because that's when the gut really starts to get stimulated. And then if you've also had something warm to drink, that's often a nice trigger to get your gut going again. Okay, next. Okay, all right. So positioning for defecation is really important. And I should have stock in Squatty Potty, I swear. I tell so many patients, please get a Squatty Potty. If you can get them at Target, Walmart, online, anywhere. And I recommend, depending on the patient's size, a 7-inch to a 9-inch high Squatty Potty. That position puts the anus in, at this unfortunately, this patient should, or person, should be leaning forward more. They're too upright. So, and most people aren't going to have their knees up to their shoulders. So they're going to lean forward a bit, and probably their knees will be about 25, 30 degrees higher than your hip joints, not almost 90. Anyways, doing some nice deep diaphragmatic breathing. Another thing is having them do like a big belly breath. So you have them puff out their belly, pretending like they're a blowfish, but it's in their belly. That helps to open up the pelvic floor quite a bit. If you have them turn their heels in and then have them turn their heels out. You have them do that 6 to 10 times. That's very helpful in releasing the pelvic floor muscles. There is a recipe that I highly recommend. Everybody claims it as their own. I do not. I got this off of a Johns Hopkins website, and it's a wonderful recipe for A, constipation, and B, if somebody has really loose stools, it's super helpful to help firm them up. So what it is a cup of applesauce. I always tell my patients unsweetened. A cup of prune juice. Everyone loves that. And then a cup of wheat bran or oat bran. There is a difference between the wheat bran and the oat bran. Wheat bran has a heck of a lot more fiber than oat bran. So you have to consider, you know, what do you think your patient can tolerate? Anyways, they mix this all up. They take 1 to 2 tablespoons only of this per day. The excess, because obviously we've just made a ton of this stuff, can go into ice cube trays, and each morning they can take out 1 or 2 depending on what their needs are, and, you know, put them in their water, orange juice, whatever, just like make a lollipop out of them. Anyway, it really works for a lot of people. Can't promise everyone, but a lot. Okay, next. I had to show this. I know we've been going on for a while, but this you cannot miss. This is the Health Jolting Chair. It is, I swear, pre-squatty potty. I can't read it, but I'm sure you sat on it and your bottom got jolted around. The rectal dilators for piles and constipation. How in heck the rectal dilator was going to do anything when you're constipated, I have no idea, but just thought it would be good to see. All right, next. Okay, so neuromuscular, and to be honest, I'm pretty basic with my neuromuscular skills. I can do some basic testing. The timed up and go seems to give a pretty good indication of what somebody's balance is. It's one of the things I'm looking for. And the stance test is certainly a much better indicator with the eye, or it's another good indicator of eyes open, closed, semi-tandem, tandem, and then standing on one leg. If you feel like, you know, somebody's got a lot of they've lost of their fine motor skills, I send them to the OT. I don't feel as though I'm going to be able to provide them with adequate help. If they need assistance with gait, and it's a simple thing, just like getting a walker or a cane and doing some training there, and that is adequate for them, then I can do that. But if it's a bigger issue, then I will send them to neuro. They're so helpful. Okay, next. So here we have some of the resources. It's not an extremely comprehensive list yet, but it gives you a starting point. I've given directions like www.cancer.net and how to get to where you want to go, like to cancer care and how cancer is treated. It's a nice way to, like, if you want a little bit more information about what's going on with your patient. The NLN is number 2, the cltlana.org, and for www.cancer.org, and then eatright.org. One of the best for is pelvic floor assistance or lubricants or any kind of information you might want about pelvic floor, sexuality, urinary incontinence is sexualityresources.com. And then there's the Pelvic Floor First Continence Foundation of Australia. And last but not least, the APTA. So I want to thank all of you who are either here or, the final key points. Okay, I can't thank you yet, right? So the final key points are that we, as pelvic health, oncology, physical therapists, and, you know, when I say that, I really think that all of us are, even though we may not think of ourselves that way, but the orthopedic therapist is important, the neurotherapist, the lymphedema therapist, the pelvic therapist. We all have something to offer, including the speech therapist, the occupational therapist. So all of us are involved, or even if we don't even know we are, we're going to be. And pelvic health is something I feel so passionately about, that we need to address this with our patients, because bowel and bladder and sexual function is so basic to our daily lives. All of us, and I'm so included here, all of us can benefit from high-quality oncology rehab courses. And certainly I know that Oakland University has them, and there's a woman, Julia Osborne, in Colorado, who has a PORI Institute, P-O-R-I, very good. So there's a lot out there, but we're not mainstream yet. So I hope any of you who are listening will be inspired to become mainstream. All right, I'm going to close it off now, and thank you very much, and see you later.
Thank you, Virginia. This was really important information. I'm so glad that you're advocating for this, because this is such a critical rehabilitation concern. And I think, you know, we've done a lot more research with breast and prostate cancer and lung cancer. And, you know, some of the things that you and I have talked about is this is sort of a hidden area, but it's such a vital area in terms of pain and function and quality of life and overall health. So I'm so happy that you're bringing this to the forefront, and I want to thank you and congratulate you on a wonderful presentation. And I'm hoping that you will be presenting at the APTA next January so that we could get this information to more people. So thank you again, Virginia.
You're welcome.
This was really good. So this is all recorded. We had at least one person came in and watched for a while, but I know this is an unusual time for a lot of areas, so I would be expecting that there's more people that watch the recordings. And so without further ado, I'm going to close out the session, and thank you all for listening to this important information. Okay, goodbye all.
Hello.
Oh wait, looks like we might have had a question here. I'm so sorry for joining late. I have no sound. I've tried everything. Apologize. I'm really keen to hear your webinar. I'll have to catch it at a later date. Okay, thank you, Thamra. We will talk to you later. Take care. Bye-bye.
Okay. Are you there?